Good morning, everyone. It's Friday, the 30th of January, and we're starting off this morning with DMH and their budget presentation. Welcome.
Thank you. Good morning. For the record, Emily Hawes, Commissioner for the Department of Mental Health. And with me today, I have
Samantha Sweet, Deputy Commissioner at the Department of Mental Health.
So thank you for having us today. DMH will be going over our FY27 budget. I'd like to first start with how the Agency of Human Services approached the budget work this year, which was from an agency of one lens. So over the course of the summer, the group of commissioners and the executive leadership team for the Agency of Human Services met weekly to go line by line of the different departments' programs. As we knew, we were facing a fairly challenging year from a budgetary perspective. From a DMH lens, we operated with this work under the core values for the department, which is compassion, equity, integrity, collaboration, and accountability. Grounding ourselves in those core values and beliefs were a pivotal foundation for this work as we went line by line. As we go through our testimony today, Deputy Sweet and I will highlight some budget pressures. We'll also be proposing some reductions to the budget. For general awareness, DMH provides oversight and designation for 10 designated agencies, 2 specialized service agencies, 6 designated hospitals. We operate the Vermont Psychiatric Care Hospital in Berlin, as well as the River Valley Therapeutic Community Residence in Essex. As a department, we have around 326 positions, which 245 of those are within those 2 facilities that we operate, which are 24/7 facilities. That also includes a business office at central office, administrative support, our quality department, research and stats, care management, operations, all of those functions that are necessary for our department to operate. We also collaborate with all the Vermont hospitals. We have contracts for forensic psychiatry, and we, in addition to working closely with our community partners, such as Vermont Care Partners, the National Alliance of Mental Illness, Pathways Vermont, and many others. This is a snapshot of our current organizational chart. This information can also be found in documents submitted, so I might skip through some of this because you've either seen it or it's easily available. But if there's questions or if I'm moving too fast, I'm happy to slow it down. From a vacancy perspective, since vacancies at our 2 facilities greatly impact our overall budget, I wanted to provide a quick snapshot into the vacancies currently existing within the Department of Mental Health. So as you'll see here, the red line being a positive trend, which is a lower vacancy rate than we have faced in the past 5 years. In 2021, we had around a 60% vacancy rate at that facility, and we are now down to around 37%.
I'm just comparing, as you say, 1 year ago to today, and it goes from almost 33% to 31%. How many positions does that represent?
Are you talking the overall?
The red line.
Sure.
I'm looking at your text 1 year ago and then today.
Yep, and depending on which line item you're looking at, so the red is the hospital.
I'm just looking at your blue, where it says blue, 1 year ago and then today.
Oh, okay, that's overall, so that encompasses all of the positions within central office, River Valley and VPCH.
Right.
So if you want specific, we can get that to you.
No, I'm just curious to know, because you said it was 33% down to 31%, and how many positions that represents.
Got you.
I'm curious,
Got you.
the absolute number rather than.
Yeah, gotcha.
Brian, is your question?
What is RVTR? River Valley, okay, so it looks like there's a decline in people working in direct care and an increase in people working in administration. Is that true or not?
That is not true. So we have more vacancies now. It's central office, which is our primary administrative, right? Our central office is around 18%, and that has gone up. That's the blue line. We have more vacancies than we've.
Oh, it's, okay, this, I see, so this is actually like the rate of opening going down. So you're filling positions doing direct service more, and there's more openings in central office.
Correct.
And so I probably should look ahead before I ask this, but I wonder if those are opportunities for savings that you might identify.
Yes, we
Okay.
have identified opportunity for savings across the entire department. And we're happy to go through that a little bit more as we go through our reduction proposals.
Hopefully not your finance manager. though. Daisy, you have a question.
I did look ahead and
Yeah, sure.
because this is your budget testimony, I'm concerned because you don't get to budget until slide 26 and there's a lot of overview coming up to that. So I just want to make sure that that we're talking about the significant amount of cuts that DMH has. I mean, half of your budget sheet is red.
Yes.
So I hope that you're going to weave in the reason for those cuts as you get to slide 26.
Absolutely. When I started off, I did, if the committee wants to go faster, happy to skip through some of this, although I do think it's important to highlight the successes and work we've done around 988 and enhanced mobile crisis in our mental health urgent cares. Happy to tailor to that and then get into the budget ups and downs and summary if that's how folks would like to go through that, because we're aware that there's lots of questions and there should be around those reduction proposals. And so we want to be able to honor that opportunity for folks. So with that said, I'll go ahead and move over to our crisis system of care and highlight the work that we're doing within the 988 segment. And so that would be slide 14, please.
Right. So many of you have heard me talk about our crisis system of care before, but as a reminder, the way we look at this is the person on the left is the least restrictive, all the way up to crisis beds. And so this is our community crisis system of care. So we don't include hospitalization, things like that. So when the person is in crisis, they can access 988, enhanced mobile crisis, or go directly to a mental health urgent care. And we currently have 6 mental health urgent cares throughout the state regionally. And we collect a bunch of data around the mental health urgent cares to understand who are they serving, what are the numbers, and looking at it regionally. Our enhanced mobile crisis also resolves most crisis in the community, up to 81%. And then what we see on 988 calls, chat, and text is that 95% of calls have been resolved over the phone. Great.
I'd also like to just mention recent work done within the crisis bed system to integrate the crisis bed capacity for those facilities to be able to serve individuals in both a substance use and mental health crisis. I'd also like to highlight that with 988 and with mobile crisis, those are also co-occurring, serving individuals who are experiencing a mental health and or substance use crisis.
So next slide, just taking a minute on our screen. So 988, like I said, it offers call, chat, and text. And we have trained counselors answering those phone lines 24/7. We currently have 2 agencies in Vermont answering all the calls, and that's Northwestern Counseling and Sports Services and NKHS, which is Northeast Kingdom Human Services. Our vision has always been about enhancing our crisis system of care. So how is 988 interfacing with enhanced mobile crisis? How is that interfacing with enhanced mobile crisis or mental health urgent cares? And so we're really looking at what are our goals for that system and moving that system toward those goals. Next slide. So as you will see, there are about 1,750 calls on average during a month. In November, we saw a little bit less calls, and about 82 are answered in the state. And so what that means is that a Vermonter calls or texts or chats with 988, 82% of those are called by someone within the 2 facilities, 2 agencies. If they're not able to answer the phone call, it does go to a national backup line. So someone is always answering. Our goal is to get to 90% answer rate within Vermont. So Vermonters are answering Vermont calls.
I'd also just highlight from a utilization perspective, Vermont is one of the highest, if not the highest utilizer of 988 per capita. Also taking an opportunity to highlight the transfer protocol.
Yeah.
Okay.
Do you want to go?
No, go ahead.
Okay. So over the past year, we've been working on 2 big initiatives. One is with 911. We are the first in the United States to have a call go into 911 and that call be able to be transferred to 988. So a warm handoff to 988. This allows us to be able to respond with enhanced mobile crisis instead of law enforcement. So we're really excited about that. It just started within the last couple of months.
Does the 911 operator make the determination?
Yes, there's a strict protocol because this took a lot of work to have guidelines around 911 because they're very clear of like, if someone calls, they're experiencing chest pains, they can flip to what to exactly do. Mental health is different, right? You could have a caller calling about anything. And so we have some key words that get picked up by 911. They understand if there's any question, they can move ahead with keeping it in the 911 track. But if it's clear mental health, they'll divert it to 988. Let's see. So I talked about the 90% answer rate, which that is our goal. The other thing I will highlight with 988 and enhanced mobile crisis, which I'll get into a little bit more. You'll see in 2025, we started a new software called BHL, which is Behavioral Health Link, and it allows dispatch from 988. So a call comes into 988, it cannot get resolved over the phone. They can dispatch through this platform enhanced mobile crisis.
Statewide.
Statewide.
Brian?
Is BHL the app that crisis workers are being asked to install on our phones?
Yes.
So just so we don't need to get into it now, but an ongoing issue is that no one is telling us how our data is shared once we put it on our phones. And we're also being told that we have to put it on our phone. But like, what if we don't have a phone that we're bringing to work? Like, is the state going to provide us with phones then? If it's honestly an issue for me because I don't want the state having access to the data on my phone just because of my job, you know?
Personal phone is out.
Yeah. So this is an emerging issue, and there's been like also some confusion around how are the resources of local crisis teams going to be managed if there's this external force like poking its way in and And so that, I know that people are working this stuff out, but I'm just
Yeah.
curious if the state could look into more, be more transparent maybe about how BHL uses data, maybe even including it on the state AI inventory, if it's gonna be collecting data by the, I don't know if it is by
Yeah.
those standards.
Yeah.
I don't know if you have more to share about how it works.
Yeah, and we could definitely have our crisis director come in and talk. He is intimately aware of all the workings of 98 mobile crisis and the urgent cares. And so he would be able to have a one-off conversation with you two and come to this committee and talk further. So mental health urgent cares. I said earlier, we have 6 throughout the state right now. We are gathering data to see the utilization of all the data. We are looking at an approach to do regionally, so that we have each pocket of the state will have mental health urgent cares. We went this approach as we know that the emergency rooms are not
Therapeutic place.
thanks. I couldn't find the word. Therapeutic place for those experiencing a mental health crisis. And so we have found that the utilization is very high. It lowers the stigma. It's very person-centered. We have clinicians and peers embedded at the mental health urgent care. And what we're finding is that the utilization for the peer support is actually much higher than those seeking clinical counselors.
6 active programs, how many of them are youth centers?
Focused.
Okay.
We have 2 out of the 6 are, and then we have 1 that is serving the whole age span. So 2 are specifically focused just on youth and 1 is the whole age span. Our goal is
Rutland and what's the other one?
nope, not Rutland, it's UCS, so Bennington area and then HCRS area. So Wyndham and
Healthcare and rehabilitation services,
Wyndham Windsor.
Yeah.
Wyndham Windsor.
So in southern Vermont, there's 2 pediatric or youth focused urgent cares, and then in the north in Burlington, there's the adult one. Okay, just to.
And then Northeast Kingdom is serving the age span, and our goal is to get every mental health urgent care to be able to serve the whole age span and to increase the hours. And
That goal would be 24/7.
Oh,
As
wow.
we know, as long as there's an opportunity for someone to go to the emergency room, that we are as humans, that's where we're gonna go, because we don't have to think about when an emergency room is open, it's always open. And so getting to that 24/7 is really valuable from our perspective.
Now, these are not billable services, correct?
we are working toward that, yes.
So with this rural health transformation grant,
Mhm.
what is the hope? Because I know this is a part of it, is
Mhm.
building out this system of mental health urgent cares across the state. What is the hope in how we're going to go from 6 to what number?
We'll still continue to look at a regional perspective from a mental health urgent care. The last couple of years, we've had an opportunity to gather data about how many people they're serving, and also what communities are responding the most to. And so there is mental health urgent cares as a part of that RHT. There are some parameters about what we can utilize those dollars for. We also have our certified community integrated health center, or CCBHCs, which there is likely an opportunity to combine those mental health urgent care rates into that CCBHC rate.
Brian, did you have a question?
That. Top first.
No, I had not seen Leslie, but
It's a quick one, I think. That, is it like, if people go to an emergency room and they go to the triage desk or the intake desk or whatever it's called in whatever facility, and are they being screened and referred to urgent care if the triage nurse, whoever determines that that might be a better, or do they get taken into the emergency room, go through the whole emergency room process and then get sent there if it makes more sense? Because I'm wondering if that's an area for savings, if there was some way to deflect people or refer them. It's like, it's not meant to be like deflect, like it's a bad thing, it's a good thing. If you know, like a more appropriate use of resources, is there any kind of efforts to look at how to do that, or is that happening at all?
Yeah, a lot of work has been done by our crisis team to go into and meet with every hospital so that they know about 988 mental health urgent care and our mobile crisis. So I would love to say, yes, we can divert that, but when people walk in the door, they may be seen there. So even though we put a lot of effort into showing how other ways that they can seek mental health treatment.
I may be getting ahead of myself, so accept my apology. I'm just trying to understand, I understand these are the programs, but I'm trying to understand the connection between these programs and your budget. Is there a connection? And where can I find a cross-reference? Well, and you may be getting to that, but as you know, Daisy said, it's later on in your presentation. So I'm
Yeah.
trying to understand the cuts because there's a lot of red and how that red is going to affect all these programs you're talking about and that interaction.
Sure. So why don't we just skip over to the FY 27 budget? For folks who we sent our slide deck ahead of time, please feel free and look through that and ask us any questions you might have, especially if that's related to the psychiatric residential treatment facility, which is coming online at the Brattleboro Retreat in 2026, and an inpatient adolescent unit at Southwestern Vermont Medical Center. And those capital contracts and operational contracts to the sum of around 10 million are in the finalization of being sent out to SVMC for signature. So you'll see on slide 26, this is a summary of the budget for the Department of Mental Health proposed for 2027. And this breaks out, I think I saw a question from yesterday's testimony about two things, how much money is in grants, how much is in Medicaid. And so this first slide is a pie graph of those. So you'll see the big green is Medicaid Global Commitment Funds. We have a slice of federal funds, and the dark blue interdepartmental transfers are the dollar amounts that go between the Agency of Digital Services, Human Resources, General Fund, and then Medicaid investment dollars, which is missing its title. Then
What?
it's missing its title. on
Okay,
the-
thank you.
that's that.
Oh, I see it now, yeah.
Breaking that down farther is the breakout across the system of care. And so from a budget perspective, around 71% of our funding at DMH goes to community-based programs. Yes.
Sorry, I'm just comparing. I'm sorry, the one you were out.
Oh, the one
No,
before.
no, that one.
Okay. Oh, she's running the slides, not
Oh,
me.
hi.
For us, I was.
You thought you were doing it. It's magic. I just like putting it to last year. Thank you.
Yes.
Sure.
Daisy.
I see two PNMI blocks on the left. Can you remind me?
Yes, there are two different types of PNMI. We have the PNMI full residential. We also have some crisis beds that are part of PNMI and out of state PNM, private non-medical institution.
You know which of those represents which?
Yes, so the bigger, the green is the PNMI crisis beds, the out-of-state placements for PNMI residentials. So the bigger slab is, or bigger slice is that rate for the programs.
Is there a reason that you've included like residential and out of state all in the same chunk of pie? And is
That's
there a
how it's
break?
broken out in the ups and downs. And so this is a reflection of that.
Okay,
But we can talk a little bit more with finance folks about the differences between separating those out.
yeah, I mean, I'm really curious about the out of state component.
Oh, yeah. Do you have specific, we have quite a bit of data related to the out of state placements.
Yeah, there's a slide in the deck early on that shows you exactly how many go out of state for fiscal year, if I remember correctly, without it being in front of me, fiscal year 25. And then the slide on or the table on the left is a point in time. So I think that's January 22nd. You'll see that's a very specific just day today, how many people are out of state, how many people are seeking for all three departments, DCF, DMH, and Dale. So that's early on in the slide deck, if you want to go back.
Slide 22.
Thinking I was looking at it, I just looking for a breakdown of how much of that $73 million is going out of state.
Well, good question.
That's,
We don't have that in front of us, but we can definitely get that.
that's right, you said no numbers questions.
Which is hard because I realize we're giving budget testimony.
Yes.
So I do want to be transparent about that. So for the appropriations committees, we're not going through the ups and downs. We're going through a summary. Was the summary okay for this group, or would you like for us to go down the specific ups and downs?
I think this,
Because the summary is what our pressures are. We have a couple of initiatives and then primarily our reduction proposals.
I think we sort of like to know what's going up,
Mhm.
what it is, and what's going down, and what that is.
I'd especially like to know more about the forensic work since there's a buzz about that currently.
Okay. You might not see much in our budget related to forensic work. That's outside of the DMH budget, but
Whose budget is it?
well, right now there's not a budget with that, I don't think. So say no thanks. But there are components of folks who are labeled, identified as forensic across the entire system now. I can talk a little bit about how that impacts our budget. Right now, I'll highlight that our current budget ups all under traditional salary and fringe, our benefit rate in changes. We have increases related to a federal requirement for the pre-admission screening and resident review nurse, which is also known as a PASSAR. That is a required federal screening for someone to have in order to be assessed for appropriateness for a nursing home level of care. We also have a net neutral shift for the forensic assertive community treatment. So it looks like an up, but it's net neutral. And that is a MOU that we have with the Department of Corrections to engage with folks at the community level. Also, the PNMI budget pressures, which we talked about in our BAA testimony, that's related to utilization and rates increasing.
Is the fact, is that T2?
It is not.
That's why I brought up forensic, is because I saw that.
Yeah. The FACT is an evidence-based model forensic assertive community treatment, and it's essentially a wraparound case management engagement service for individuals who are engaged with the criminal justice system and have other types of case management needs. And Pathways is the organization that delivers that service.
These are people who are justice involved, who also are struggling with co-occurring disorders? Okay. So it's providing like extra treatment as part of the criminal justice process?
Yeah,
Okay, yeah.
in an outpatient setting, community setting.
Yeah.
Yeah.
So it's community-based services?
That's correct.
Yes, thank you.
Outside of a hospital, DMH doesn't contract for any services within the prison system. These three budget initiatives are additions to the DMH budget. So continuing our work expanding the behavioral health link, which is the program that we talked about earlier, and we'll follow up around data concerns or clarifications. But does centralized dispatch for enhanced mobile crisis from that 988 call. We also are requesting for the authority to spend additional dollars as it relates to the Universal Service Fund, which DMH and 988 is a part of a waterfall of priorities related to the Universal Service Fund. I think we're like 5th on the list there, and we want to make sure that we have the authority to spend that money on 988. And then related to our CCBHC initiative, we have 2 current agencies who have moved to the CCBHC daily rate. And we're in the process of certifying 5 more. And we anticipate those being online in July of 26. Currently, the state of Vermont is in a demonstration status with the federal government, which means that those agencies receive a enhanced federal rate for the services that they provide under the CCBHC model. And there's a lot of information about the CCBHC model in the packet. And I would ask that folks, get familiar with that. That's really the foundation of how we're looking at streamlining and improving the quality and access for care for mental health and substance use services.
Can I go?
Oh, yes.
So for these specifically, are they in the ups and downs somewhere so we can see the amount related
Yes.
to each?
Yeah,
Okay,
they are.
Thank you.
Yes, they are.
Okay, thank you.
It'll be in the non-facility.
Okay.
So there's 2. There's a B314 and a B315. I think 314 is central office. And
This is in central office?
Yeah.
Okay, thank you.
You're welcome. So the next slide is several proposed reductions. And I'd like to again reacclimate ourselves to the work that the executive leadership team did over the summer, looking across the entire book of business for the Agency of Human Services and being guided by those core beliefs and values at the Department of Mental Health. Understandably, folks are going to be impacted. From our perspective, we do have a system in place that can appropriately serve folks in our communities. So first up is mental health training for first responders. Representative Rebecca, this is the Team 2 training. Team 2 was developed and implemented a little over a decade ago when DMH did not have a crisis team within the Department of Mental Health overseeing the implementation of mobile crisis and 988. Over the past couple of years, DMH has been able to grow that team, and we'll be shifting the training for first responders in-house and taking that over within the department instead of contracting that out. And we do feel that we can absorb that within that current team.
So trying to break it in pieces, 1, without spending additional funding, you believe that, you believe, but you're
We're confident.
reporting that, you're reporting that.
Mhm.
The existing staff can provide training for basically it's law enforcement and mental health workers together.
Absolutely.
And is it possible that you could expand the training without spending more money and provide more training than Team 2 does?
That's a really good question. I don't think we're there yet. What we would prefer to do, is to take that training in-house, make sure that it is seamless from an integration perspective of 988, enhanced mobile crisis, CCBHCs, with a strong emphasis on persons with lived experience. And once that happens, I don't think we're ever at a full array of training, right? There's always more training we can do regardless. But we would analyze that as that transition happens and shift training as needed.
Would it be possible to, so currently the DMH, I don't know if DMH is the one, I can't remember if DMH is actually the one like who is implementing the training using remote means for crisis teams with the CCBHC, but there's, you know what I'm
We
talking
have a
about?
contract for that, yes.
Yeah, but you're paying for it.
Yes,
You're overseeing it.
Mhm.
It's high quality, for my opinion, for what it's worth.
from an enhanced mobile crisis
Yeah.
response, yes.
Why, is it possible that law enforcement could just do that same training? That same remote training, because then they would at least have the same language as the crisis workers. Even if you weren't cutting team two, I mean, that's just the way, like, if you already create the program, is there really much additional expense with just having every law enforcement officer in the state be asked to do that as part of their duties, that those additional, whatever it was, 15 hours of training over the course of a year, like?
Yeah. My first response is this is a budget reduction. And so we'll need to streamline how we train law enforcement. What I do think is a benefit to this is that when you are able to do that in-house, there are opportunities for better integration across all the platforms that we are serving our community with, right? You know, there's a shared language across folks interacting with each other and community members is incredibly valuable. And that's what we would aim to do.
Yeah, for what it's worth, and this will be like my last interaction, because I don't want to take too much space, but
Yeah, and I'm just cognizant of time here and I really want to get through these things, so
Yeah.
let's.
I think the greatest loss is going to be having law enforcement officers and mental health workers be together in a space and build relationships. So that, I think that's going to be the biggest thing that is lost from this being cut, is that, and so if there's any way that can be preserved or expanded.
That would not be our intention to
Okay.
not do that.
Okay.
That we see that as a very valuable
Yeah.
interaction for folks. And so training law enforcement and supporting the work of folks who are working within the crisis system or first responders, that is still our commitment. This is a reduction for that particular contract for Team 2 and taking that in.
And I guess the other thing is that if you're going to be reconsidering how you train people, the workers, just if maybe a reminder that the Health Equity Advisory Commission talked about a whole of government approach to training, and this might be an opportunity to look at how is investing money in training. Can we invest money in training in a way that helps more workers, not less?
Absolutely.
Putting it out there,
Yeah.
like.
Great. The next
Sorry,
line
thank you.
item is our bed board. So if folks who were around with Tropical Storm Irene, the state of Vermont implemented a digital bed board, which gives a point in time notice of available beds across the system. We have shifted that bed board contract in-house. And so that is a proposed reduction of, I think it's around $15,000. We'll no longer contract that out. That is going to be moved within the state of Vermont.
Where in your budget is that?
It's on the budget ups and downs sheet. Sure. It's listed in the red. So small, isn't it?
Yeah. I had to print it.
Yeah, I can point it to you in this.
I'm just trying to parlay here the money and the program, but maybe that's not the right.
So all of these things that are listed up here is that chunk of red at the bottom of the one slide. Page
Yeah.
29.
Yeah,
Connection
yeah, I
there.
think
Let
we
her-
need to, yeah,
They
yeah,
need to get
got
through
it.
this.
So the next line item is project management related to suicide initiative, otherwise known as the governor's challenge. We currently contract out project management for that work. And since I would say, I think it was legislative session 2021 or 22. We now have a director of suicide prevention. And so we would continue that work in-house. We would no longer contract that out. The next line item is nursing services at a community care home. There's one community care home in the state that the Department of Mental Health funds nursing services at. And that is at Kirby House in Washington County, Waterbury. So our proposal is to reduce that nursing services and explore transitioning that into a CCBHC rate or explore other avenues for nursing services for individuals who are living there. The next line item is DMH outpatient services related to the TBI waiver.
You skipped one.
Oh, I did. That wasn't on purpose, I promise. And you have shoes on. That wasn't on purpose. So last year, this was also a reduction proposal from DMH. And so we are re-proposing it again this year. This is a $160,000 line item for community outreach for Chittenden County. This is community outreach services to the broader Chittenden County area, such as Heinsberg, Richmond, Winooski, Essex. I was getting there. I saw it. That impacts several folks in this community. From a data perspective, a majority of these interactions with folks are phone calls. And we would like to direct that interaction to 988 and better utilize our 988 to mobile crisis to urgent care system that we've implemented. Anything else you want to add?
Yeah, I'll just add that this provides services or is contracted with 9 cities or towns. And 2 out of the 9 receive less single digits each month of contact. What we also see is in a quarter, 35% is face-to-face. So you have 65% either on the phone or doing collaborative work with agencies. So we also feel like this is a duplication of services, and we really want to utilize enhanced mobile crisis for this. What we also know is it employs 5 to 6 staff over 9 towns. So that's less than 40 hours a week that each town is receiving. And so where mobile crisis is 24/7, can be dispatched at any time, move those staff into enhanced mobile crisis team.
I'm just gonna say, I have a ton of questions and I really want to see the data on this because I hear the exact opposite from my community.
Okay.
I have
We
called
can
them
share.
myself as a business owner.
Mhm.
And I'm not sure enhanced mobile crisis would respond to the calls that our community has for this case. So I would just love to see the data.
Okay,
Thank you.
yes, we can share that.
Can I clarify one thing for the committee too, who might not be familiar with this? This is, in terms of crisis response, the lowest barrier because they do not collect data from people. If they go into this 988 approach, they're going to need to collect data from people who are in crisis.
988 also doesn't collect data. So that is an opportunity for both a business owner could call 988 and a community member can also text.
But just the outreach. If someone
If they require,
street.
yeah, if they require outreach, and we can loop back to the 988 data, most are resolved over the phone.
So when we say data, I just want to be clear, it's like name, insurance, that kind of information. Both community outreach and enhanced mobile crisis and 988 all collect data. That's how we get our quarterly report from the community outreach team. What is different is it's not really different. If someone refuses to give their name, insurance to enhanced mobile crisis or to 988, there's nothing we can do. We will still serve them. They're funded to also serve the underinsured and uninsured.
I will just say that my concern with this is that when you call everything a crisis, it becomes a crisis.
Understood.
And this is not what that is. Brian.
Yeah, well, it sounds like we are gonna dig into this more later, so I don't wanna prolong it now too much, but I do think it's an important thing just to understand what you're proposing. That it sounds like you want to, you in the plural, not personal, but like, you know, the administration, so it doesn't feel like it's personal or anything. The administration's recommending that we cut the funding, but then meet the need through the existing structure of crisis.
Can I push on that? a
Yeah,
little
or
bit?
explain it more. Yeah,
so
yeah. explain it.
Community outreach was put into play before 988, before enhanced mobile crisis, before mental health urgent cares. And so we have those in play now. We want people to utilize them. And this is an opportunity to push the system a little bit. And change also is uncomfortable. Chittenden County is the only county in the state of Vermont that has this program.
So then if we were encouraging people to use 988, that would mean like a business owner in Essex would call 988, get a dispatcher in the Northeast Kingdom potentially, and then that dispatcher would have to somehow understand how to activate the crisis team in Burlington to respond to Essex in an appropriate way. I'm not saying it's impossible, but that sounds like a lot more complicated and not as efficient as having a relationship directly with the local team where you just call them. The person on duty's phone rings, they answer it. They're like, I'm one town away. I'll be there in 15 minutes, and they show up. And they also do co-respond with us for mobile crisis when it's not like there's like, just so everyone understands, there's like assessments where a clinician might go alone to a home. And then there's mobile crisis responses, which are recorded differently. And when we do mobile crisis responses, a peer goes or a community outreach worker goes. So you're saying that the co-responder would be some way otherwise embedded in the existing program, you know, like if you cut, that's like, how are they going to be folded into the existing program? Who's going to do that work? Who's going to be the co-responder with the crisis clinician?
Sure. Do you want to take, I
Yeah.
think you have the best answer
Yeah,
for the
so
co-responder questions.
the co-responder can be a clinician and a paraprofessional, which includes a peer support worker. So it can also be paraprofessional is the community outreach worker. So that it is a 2-person team. And so did I answer your question?
Well, I don't understand what difference it would make if we cut that program, but then we have to just hire the staff in another program, you know, because like you still need the co-responder to go with that.
Yeah, so I'll loop us back
Okay.
to the work that we've done from a budget perspective and a line by line analysis of all of the programs across the Agency of Human Services. And when we look at this line of $160,000 and we compare that to 988, enhanced mobile crisis, mental health urgent care, and the services that are available to our community members, this is a proposed reduction for that 160K. I'll keep us moving
Yeah,
because we aren't even halfway through, but I certainly understand the questions and appreciate those. The next line item is a reduction for outpatient services that DMH holds for individuals on the TBI waiver. Our partner department, Dale, continues to serve individuals with TBI. There's one individual who is a part of the DMH TBI waiver. Also elder care and reach up. So I'll pause there. Folks who are currently engaged with these services will still have access to services. They will not be under the umbrella of elder care, TBI, and reach up. And that is because we see it as a duplication of services across the system. Next line item is a reduction related to the Vermont Collaborative for Practice Improvement and Innovation Training. This is a reduction for training to the overall mental health system for clinicians and other providers within the system. The next line item is related to designated agency special services. This is a under or non-utilized special services fund of around 7,000. I think it's like 74. for respite services for youth.
And this was attached to IFS. And so you'll see in a different slide where IFS funding went back to DCF, Dale. And so this is just eliminating funding that was not being used.
Briefly, IFS is.
Oh, Integrated Family Services. Thanks for stopping me. We talk a lot of acronyms, so
What is it, 1,500?
yes.
Acronyms? The next line item is puppets in education, which is an educational component that goes around to schools and teaches young people about anxiety, depression. So we would propose to reduce that.
Because
Well, that is funded in a way that we have to specifically target individuals who are experiencing an early mental health diagnosis. And when we are incorporating that into a broader school system, we're not able, it's a risk for us. We're not able to comply with the requirements of those dollars. Next up is care coordination for children. This was a reduction proposed last year. This is what's called Medicaid admin dollars. So dollars that clinicians and the Howard Center in Chittenden County. So this line item funds one clinician at the Milton Family Practice. The Milton Family Practice is also a Blueprint practice, and so there are embedded clinicians within that practice. And the Milton Family Practice is the only practice in the state that has this one FTE funded by DMH. It also serves as some capacity funding for First Call. And the functions of the EPSDT dollars are to connect community members, children and families with signing up for Medicaid, Dr. Dinosaur, and insurance. We see this as a duplication of service and can be absorbed within other case management services in the state. The next line item is a program for Washington County Mental Health, known as the Collaborative Systems Integration Project, or CSIP. And this program was developed and initiated after Tropical Storm Irene to serve one individual who did not meet eligibility for TBI programming or a serious mental illness. Since that time, that individual has since moved on, and Washington County is now utilizing this as an outpatient residential intervention for justice-involved folks. They are the only agency that has this line item, and we would propose to reduce that. Individuals would still have access to services. They would not have access to services under this budget line item. Thank you. Safe Haven, Generation 2 at the Clara Martin Center is a residential program. This is a line item that they would no longer prioritize individuals who are uninsured or underinsured. Youth in Transition is a grant that is held specifically in our designated agency system to serve youth as they transition to adult. We propose to reduce this line item and have those services be absorbed into the youth and family programs as well as the adult programs if that's appropriate at that agency. The last on this list is a proposed bed reduction at the Vermont Psychiatric Care Hospital, which is a 25-bed currently, a 25-bed hospital for adults who are receiving hospital level of care under the care and custody of the commissioner, so involuntary. Since COVID, that hospital has not been able to get above a census of 21. And we propose to take those 4 beds offline, so that we are not needing to try to hire into those vacant positions, or contract with travel contracts to fill those, to serve that unit.
So you are unable to staff the beds, not that the need is,
You know, the need for
Level
level
one.
1 care shifts. Level 1 is your highest acuity. It does go up and down. We have bed availability and have had bed availability over the past several years, with our current contracts within Brattleboro Retreat and Rutland Regional Medical Center. I believe in our slide deck is our wait time graph for folks needing inpatient care. And those beds have been offline for a while, and we have continued to see folks move within around 24 hours
I have a couple questions, but I just want to let the committee know that we need to move along on this. So let's keep our questions contained, and we can always get answers later, and we will be hearing more on all of these things.
I'll say that the last slide, I just put those aside due to that they're not necessarily reductions, but they do show up on the reduction. So transfer of funding from DMH to DCF, that's related to the IFS program, Integrated Family Services, is no longer active, and so we're giving money back to that program. The ARCH program has since ended, and so we are returning those funds back to Dale. Inpatient hospital level 1, this is specific to Rutland Regional Medical Center, in that we had an underutilization of level 1 beds at Rutland Regional. And then the Lifelines for Suicide Prevention, this was the line item that went to the Center for Health and Learning that has since dissolved.
Who's taking on their work?
I believe BAMHAR.
And that is what?
Oh, and yeah,
BAMHAR?
BAMHAR, yeah, the Vermont Association for Mental Health and Addiction Recovery.
And do we have line items for VAMPAR and NAMI? Are we
Those
placing
not for a reduction. We do not. Those are within the ups and downs,
not an increase?
not an increase.
Just as a reminder, we have the suicide prevention director within DMH as well. That's taking on some of the duties.
Karen, quickly?
Yes, briefly, I don't know if this is, it seems like you do have an amount for each of these items that are on the gross budget downs. Is it possible just to put a number next one and, regenerate the slide?
It is within the ups and downs.
Yeah.
Could
you, it'd be
We
super
could.
helpful.
yes, we can, and there's room for error when that occurs
Understood.
because the ups and downs is the official document.
Do
Yeah.
we have a budget book from DMH?
Well, you don't have a budget book as nice as DCF's.
That's the DCF.
I can tell you that theirs is very nice. You do not have it in the same presentation form that others have. We were, so you have received the DMH presentation and budget information following the guidelines that we were given from the appropriations committees.
Yes, go ahead.
So it would be helpful, though, to have something in writing that explains all of these programs, which I think was also asked in the appropriations request.
Yes, we will get that out to you.
Thank you.
Great, thank you so much.
Thank you.
Great. Pivoting back to page 577, and if you recall, we had Jen sort of walk us through some new language, and I thought that it would be a thought it would be helpful if we had a couple people in to see how what we're doing in this bill is affected by the changes. And I really want to start with Sebastian from DFR. Because it's been a long time since we've looked at the life of a pharmaceutical. And I kind of wanted an overview of how things move through the system, so we can have an understanding of the use of this prescription discount array RX, what that would, where it is, where it's affecting the system. Thanks, Sebastian, for coming in. I really appreciate it.
Yes.
It's happy I was able to make time in my schedule to be here with you today. So my name is Sebastian Arguego, and I'm testifying for the Department of Financial Regulation. I have historically brought a whiteboard to explain PBM related transactions and financial flows. And the feedback I've gotten is that people in the room love the whiteboard, but it is very difficult for people watching on Zoom, or particularly people watching after the fact. So I have prepared a couple of slides to help everyone visualize things as we review.
Like a whiteboard app or
Yes.
something, and do it? Oh,
There are a few whiteboard apps, but it is difficult to draw using the computer trackpads. Maybe in the future I'll have like a Wacom tablet or something that I can bring and use to illustrate.
Not with all the budget cuts.
Right. So where we're going to start our review today is with formularies. And by way of reminder, a formulary is a list of prescription drugs that is covered by a health plan. And I have on the screen just a example formulary that was in an article in Health Affairs. But the gist of what I want you to take away from this is that in general, drugs that have favorable pricing to the PBM and thus the health plan for reasons of rebating have less cost sharing to the members than drugs that have less favorable pricing. And that applies at the brand name and specialty tiers.
Could you just say that one more time?
Yes, in general, drugs that have more favorable pricing to the PBM and the health plan, i.e. they get bigger rebates or they're able to acquire that drug less expensively, they're able to get a better deal from the manufacturers. Those drugs will have less cost sharing for members than drugs with less favorable pricing. Okay, so before we get into discount cards, we're gonna just talk about how things work when you are using your prescription drug benefit. And what I really want to focus on here is that as a consumer, if you're insured, you are there are two flows of money that come from you, right? So you're paying your health plan premium, but when you go to the pharmacy, you're also paying some out of pocket. You are paying your deductibles, you're paying whatever the cost sharing for that prescription drug is. And then on the health plan side, your premium goes to Blue Cross Blue Shield of Vermont, MVP, whoever. And then when you use your benefit to purchase a prescription drug that's covered under the plan, the PBM that's contracted with the plan will reimburse the pharmacy, right? But your health plan will reimburse the PBM. Okay, so now let's talk about what happens when you're using a discount card and how this is different than something like a manufacturer coupon. So under Vermont law, we have a copay accumulator statute, which is a really fancy way of saying that any outside money or assistance that you have to pay your prescription drug copays or deductibles counts towards that. But the thing with a discount card is that it is outside of this loop. You are not using your prescription drug benefit when you use a discount card. So when you were hearing testimony from Blue Cross Blue Shield of Vermont, and they said that they supported this bill and supported the use of discount cards to make things less expensive for members. One of the reasons they did that is because it also makes things less expensive for Blue Cross. And let me see if I can dig into that a little for you. Okay, so when you're using your benefit, your prescription drug benefit, the health plan eventually has to reimburse the PBM. They have to pay for that drug at some point. When you're not using your benefit, the health plan is not paying for that drug. They are only crediting you with however much you spent. And because you will only use that discount card if it is less expensive than whatever your cost sharing would be under the plan to begin with, what they're crediting towards your deductible is less than what would have been credited if you used your prescription drug benefits. Does that make sense to everyone? Yeah. It's when you're using your discount card and it costs less than what you would have paid under your prescription drug benefit, everybody wins. With the caveat that it's very situational. The prescription drug discount card is not always going to be less expensive than what you would pay using your benefits. And for that reason, when consumers are using these cards, they have to be cautious and in terms of making sure that is this actually less expensive than using my benefit or paying whatever the pharmacist's cash price is? And you might wonder, hey, when we enacted this copay accumulator statute, wasn't there some testimony about undermining the formulary that the plan very carefully chose with their PBM? And in this case, there is not the same concern for the same reason, that it is outside of the benefit. So let me see if I can explain this. When you use a manufacturer coupon, you are still using your plan's prescription drug benefit to pay your out-of-pocket payments. But what this allows you to do sometimes is, going back one slide, is sometimes this will allow you to be able to afford a non-preferred drug. That is a drug that has less favorable pricing to the plan. So when you're using a manufacturer coupon, the plan can end up paying more. That's not the case with a discount card because the plan isn't paying anything. They are just crediting your copay or deductible.
So you said something though, you said everybody wins.
In that the consumer pays less, the health plan pays less.
But what I'm trying to ascertain is if there is less money going into the system, everybody can't win. Somebody's losing something. Who's losing? If ultimately less money is being paid for that prescription, somebody's losing money somewhere. Who is it?
Right. This is one of those situations where the answer I'll have to give is it depends on the discount card. So look, GoodRx is a prescription drug discount card, and they made headlines a couple of years ago because Kroger, which is a big supermarket chain in the Midwest, and they have pharmacies, stopped taking their card because they were losing too much money. But ArrayRx is completely different. So to the extent your question is like, who loses with ArrayRx? How does ArrayRx make money? Those are questions that I'll have to suggest you go to ArrayRx or the treasurer's office for.
Great. We have someone with ArrayRx right
Right.
after you. Keep going, Bill. Sorry if I interrupted.
I think I am just about done on the insurer side of this equation. I think that a lot of times in this room we talk about answers, and sometimes there's a difference between answers and explanations. And what I tried to do here is give the explanation from the health insurer's point of view, and I'm happy to take any questions.
Everyone understand all the intricacies of our entire.
You don't need to understand all the intricacies of the entire financial flow of pharmacy benefits, because you end up with this enormous spaghetti chart. I think what's important for you to take away is that when a consumer uses a discount card, they're not using their plan's prescription drug benefit, and therefore the plan doesn't pay for the drug.
And yet the deductible still accumulates.
Yes, but all the plan is doing is crediting that member's deductible. They're not paying anything. Nothing's going out the door.
Yes, yeah.
Okay, thank you.
You're welcome.
Thanks, Sebastian.
Yep.
Oh, actually, Sebastian. Have you seen the language that was presented yesterday?
If it's the same language that Jen shared yesterday, then yes.
And do you have any issues with the language? Do you?
Yes, there was one thing I wanted to flag for the committee, and I already flagged this in an email to Jen, but I will raise it in my testimony. So there is language on page 7 on between lines 11 and 15 that goes into that would change the definition of cash price to include the actual amount that a individual would have paid using a prescription drug discount card. What this would, the idea of this is that you'd be able to get the same price with your discount card that you would be able using your benefit. So if your GoodRx card let you have drug Y for $10, like your benefit would have to accept that as your cost sharing. We oppose that provision as written because, for instance, it would require PBMs and insurers to ascertain what the lowest possible price an individual would be able to obtain using a discount card, which is information they don't have, unlike the pharmacist's cash price, which is already in their claims processing system and then can be referenced against wholesale acquisition cost by the insurer. I think there's absolutely work that the PBMs and insurers can do to smooth the process of applying off-benefit spending to members' co-payments and deductibles, but as written, this language that would modify the definition of cash price is likely unworkable for insurers and PBMs.
Do you have suggestions for language?
I'd like to take that back and think about it. We've had an email exchange going with some of the stakeholders, and I spoke with Nancy Hogue at Blue Cross Blue Shield of Vermont yesterday. So I would say, give me a few days to mull it over with the stakeholders.
Great, thank you. Quickly, yes.
This is clarifying. This is like,
Can I just let everyone know we're going past noon?
this is a kindergarten
Sorry.
question. Sorry. When you have the word individual in this, who is the individual? Is
The
it
covered person.
the covered person?
Yeah.
But is the covered person required to do anything? I'm thinking that they come up to the desk and are they required to know anything? The covered person, what is that responsibility of the covered person?
Yeah, so the provision we're talking about here is it has to do with when you're using your benefits, you go to the pharmacy counter, and the law says that the PBM is prohibited from charging you as a covered person greater than the lesser, which is basically it basically means of the 3 options, like whatever your cost sharing is under the plan, whatever the maximum allowable cost is for the drug, or the pharmacist's cash price, whichever of those 3 is the lowest that is all they can charge you. So as the covered person, you don't need to do anything. This is all this is a part of the law that's implemented on the back end.
Thank you.
And really the issue I'm raising is that while the claims processing systems have the mechanisms in place to determine what the pharmacist's cash price is, there is no such mechanism for discount cards.
Thank you. Thanks for coming in. So we have on Zoom with us Trevor Douglas from Array RX. Hi, Trevor. Thanks for joining us.
Hi, Chair, members of the committee. I don't know if you do this in Vermont, but for the record, I'm Trevor Douglas. I am the pharmacy director for policy and programs at the Oregon Health Authority. I am also one of the co-administrators and founding states of Array RX, the cooperative procurement group and consortium that you were just talking about. One of our products, the discount card that is in 6 states at the moment.
I was wondering if you could just tell us a little bit about what makes yours different than some traditional prescription discount cards, and how you work with pricing, particularly with pharmacies. And
yes, thank you, Chair, members of the committee. I really would like to just first start and say that Array RX is different in that it is governed by public sector employees from 6 different states. Nowhere else will you find a PBM option that is operated and regulated by the public sector, where the board members of the steering committee all have a fiduciary responsibility to the taxpayers in which they serve in their respective jurisdictions and states. What makes us different in terms of a discount card program is captured in a number of different ways. You've already heard about GoodRx. I'll just say this, is that there are a number of players in the discount card space that charge access fees to even run a claim through their discount card to provide a price to a consumer. We don't do that. There are a number of discount card programs that sell patient information to other entities. We don't do that. We forbid it. So those are really key differences that we feel are important distinctions that make us very, very different from other discount card options in the marketplace. As far as pricing goes, we have a directive and a principle as the Array RX steering committee pushes out our programs to honor and respect the place that pharmacies have in our delivery systems. And just as a really important point to make sure that everyone's fully aware, pharmacies across the nation deliver 51% of adult vaccinations. During public health events, they play critical roles in the communities that they live to support other public health initiatives, whether that's providing medications that treat outbreaks or vaccines that curtail new incidents of disease. Without our pharmacy partners, that part of the public health system is challenged. And we also recognize that pharmacies have consistently and always been there for patients and are recognized as the most trusted part of our healthcare delivery system by a number of different surveys over the past decades. So we recognize pharmacies as a really critical player in our delivery system and are working to ensure that they get fairly reimbursed for the services that they provide. All at the same time as striking a balance to try to find a competitive position so that we can operate inside of the marketplace. And so what we seek to do in our pricing models is to try to deploy strategies that do provide consumers an advantage in terms of savings, but at the same time balance that with what the pharmacy receives so that they're not filling a prescription at a loss, which often happens with some of the other discount cards. I forget all the other questions, so forgive me. Please prompt me for others.
That was it. I just really wanted to highlight how this is different than some more traditional ones and, you know, particularly around your philosophy of ensuring that we're supporting our pharmacies
Yes,
that
thank
are
you.
so vital to our communities. Anyone have any questions for Mr. Douglas? Yeah, Lori.
Just, that sounds fantastic. And I appreciate the work that you all are doing on this. I'm just curious, why more states you think are not doing this? Like joining your group? Have you had conversations with other states where they've are like, yeah, it doesn't work for us?
Yeah, members of the committee, chair, if I may, this is a really good question. I think that we are currently entertaining 5 additional states to the current 6. And we've had inquiries from other states that aren't part of that 5 that I'm capturing that are in various stages of engagement with us to explore and join. And so there is interest and there is, I would say, a momentum towards not just the discount card, but more importantly, the entire array of services that we put forward. Understanding that this is a public PBM option, not one that is controlled by corporate interests.
Thank you very much for that.
Leslie, quickly, and then Topper.
Thank you.
We still have 2 more people.
Really? 2 more
Yes.
people. Okay, got it. Well, we just heard from the state of Connecticut that they had a hard time with people signing up and participating. And just wondering what your experience was in Oregon and if you have recommendations as you've experienced this.
Members of the committee, chair, if I may, thank you for the question. I think it's important to recognize that Oregon and Washington have over 2 decades of experience operating a discount card program. And so we have experience and we have experienced similar challenges as it relates to enrolling people. However, we have the benefit of time on our side and a number of initiatives over decades that have made people aware of, consumers aware of our card. And I think I would be remiss to share that upon rebranding as ArrayRx in 2022, there has been a renewed need for Oregon and Washington to really step up the public service announcements and public awareness campaigns to ensure that they're aware that what was once the Oregon Prescription Drug Program and what was once the Washington Prescription Drug Program is now operating as ArrayRx. And we have seen steady enrollment numbers since 2022 that compare with enrollment numbers that predated that transition with respect to the other branded cards. And yes, absolutely, we have a program and have resources available to the state of Vermont and any other partner state to assist with outreach and engagement.
Thank you.
Thank you. Thank you so much for joining us at the last minute.
You're most welcome.
Really appreciate it.
It's early there.
We have Lauren Bodie next, who's from the Vermont Pharmacists Association. Hi, good to see you again.
Hi, likewise. It's good to see you all as well.
We're having difficulty hearing you.
Uh-oh.
Maybe going to your ears.
Let me, oh yeah, it's not connected. Is that any better?
No, is the mic on your cord?
You should unplug her.
Now we can't hear you at all.
Okay, one more adjustment.
Oh, that's a little better. That's a little better.
Just listen carefully.
We'll listen carefully. Let's try it.
Okay.
I think that's okay.
Yeah, I think you'll be good.
You're good.
Yes.
Can you not hear us?
Not anymore. How does,
Oh.
is that going?
Now we can hear you.
hear you just talk.
Okay, great. Sorry
Okay.
about that.
We
I
can
have
hear
a-
you.
I have a pet theory that switching from Teams to Zoom, they would deliberately interfere with each other.
I'm actually having the exact same problem with my laptop as well with this. Keep
Oh,
going.
thank you. My apologies for the technical difficulties. Yes, I'm Dr. Lauren Bodie. I'm the legislative liaison for the Vermont Pharmacists Association, who represents pharmacists practicing in any setting in our state. And I really do appreciate the opportunity to engage on this issue. I also want to extend my thanks to the ArrayRx team who made themselves available to meet with us this morning. We just wrapped up that meeting not too long ago, so my apologies for not having testimony submitted to the committee in advance. But there was a fairly tight turnaround between our conversations. So I just, my intention is really to turn this over to Dr. Ryan Quinn, who is a cornerstone, who's the owner of a pharmacy that's a cornerstone of the healthcare infrastructure in downtown Burlington, because certainly I would say like he's the expert in how this is going to be operationalized in real time. From VPA, I just want to just kind of like frame how we're thinking about this issue, and some questions that we continue to have. And I'll say that, kind of first off, like as healthcare providers, pharmacists are, most times the first people to have to tell a patient that the medication that they need is not affordable for them. I cannot overstate how seriously we take this issue. And how keenly we feel it on a personal and professional level, because of the role that we play, like in our medication use system. I'll also say that, on a personal level, when we saw the ArrayRx proposal, I was feeling a lot of optimism in terms of, it would be such a relief to have a viable option. Just another tool in the tool chest to try to address this issue. The idea of having a discount card that we can offer that is transparent and accountable would be an absolute game changer, I think, for certain segments of patients who are looking for ways to make their medications affordable. We did have some very specific questions for ArrayRx, and thus, very grateful for the opportunity to meet with them, to try to get some clear answers for how this would look for Vermonters and also Vermont pharmacies. And this is because, as you saw from the testimony of from Sebastian this morning, the intricacies of medication pricing structure really cannot be overstated. And so there is a high level of detail required that would enable us to know whether engagement with a program like ArrayRx is going to be the difference between a pharmacy staying open or a pharmacy closing and depriving that community of a valuable access point for our primary care system. We feel that we still have some of these questions that are still outstanding. And so the things that we are hoping to continue to engage on so that we can say in a definitive way, yes, absolutely, this is a system that can meaningfully impact Vermonters, is we're looking for information specific to the pricing structure for how Navitus, which is the PBM that that basically administers this program, details on that pricing structure, whether that's, you know, operating in a cost plus model, or whether there's a more complex pricing structure that maybe has some variation that could be favorable or could have adverse consequences for pharmacy owners. The other thing that we're looking for is more information on what the administrative fee is. Because while it's stated that the administrative fee is not one that's intended to be paid by the pharmacy, it is an administrative fee that is coming out of what the patient pays the pharmacy. So whether that's being attributed to patient cost or pharmacy cost, either way, this is money that's coming back from the pharmacy that's getting paid to ArrayRx. And so we would like to have a better understanding of what those costs are, as a way of kind of like validating whether we think that this is going to be something that is going to be a viable solution for pharmacies in the state. And then the another question that is like top of mind for us is one of the things that we struggle with in terms of some of the other discount programs available is mandatory participation as a part of other contracts. And so we're still looking for information of whether pharmacy participation in Vermont would be required if Vermont were to sign into this compact. So those are just some examples of kind of some of these specific and admittedly technical questions, but these are the kind of specific and technical questions that are really going to be the determining factor for whether this is a part of a solution to a known problem or whether this is a different mechanism that is not necessarily solving problems, if that makes sense. So I'm happy to answer any questions, and but I'm also equally happy to kind of hand this off to Ryan to answer questions as well. So
Yeah, Ryan, if you wanted to join us. Just see if you had anything to add.
Yeah, hi. Can everyone hear me okay?
Yeah, we had
Fantastic.
I had turned up the room for Lauren, and yes, we can hear you fine.
Yeah, I have that tendency. I'm a fairly loud person. As was stated, I'm Dr. Ryan Quinn. I am the pharmacist out of Lakeside Pharmacy in downtown Burlington. I've been working in the Burlington area for the better part of 13 years, both, you know, from being a pharmacy technician to now being a pharmacist within my community. Everything that Lauren said was spot on, was dead on. But I wanted to make a point of what was said, or the question that was posed earlier. It was a very good question, and I think one that does demand an answer of who pays for this, because that was thrown around of everybody wins. I can fairly confidently say there will be two modalities of, you know, individuals who pay. It's primarily going to be the pharmacy that pays, and then the secondary person to pay would be the patient, because in an ideal scenario, the patient would pay enough for a prescription in order to not only allow the pharmacy to make money, or even just break even, as many of my compatriots will say. We love to, we'd love to make money, but we'll take breaking even sometimes. But in order to do that, the patient would have to pay more, and to not only pay more to have us hopefully hit that break even or, break positive point, but also to pay for this administrative fee that is absolutely going to be taken out of each and every prescription that is picked up through this discount card. An administrative fee is going to be paid, and that will have to get covered by the cost of whatever is posed to the patient when they come to pick up, which I think is a very important point for us as we move forward with this, if that is the opinion of the committee.
Any questions for Karen? Did you have a question?
Yes, I did. Hi. Did they, when you talked with them this morning, Lauren, did they mention that there would be administrative fee and roughly what that would involve, or is that something you still need to find out?
So, and certainly I would, I'll relay what Ray RX, which feels a little funny given that Trevor's right here. But yes, there is at least, our understanding is there is a fee that is, paid as a part of this. And while we don't have a specific number for what that fee is, I think it appears that is proprietary, and so we're not privy to what that fee is. But there was a discussion of that there is an administrative fee, and as we were kind of walking through some hypothetical examples based off of information on the website, it was explicitly stated that, okay, so in this circumstance, the patient is going to pay this price that's like advertised on the ArrayRx website, and there will be a portion of that does get passed back to Navitus or ArrayRx, and it is not necessarily it does not remain whole in the pharmacy.
Two more follow-up questions. Yes, one is we've heard a couple of times now that ArrayRx is pharmacy friendly and that they take into account, the trust that pharmacists have among folks. And is it that you don't know yet if they're pharmacy friendly? You still need to find out more to see if that's the case. And then the follow-up question is it possible that the pharmaceutical companies, the drug providers, are the ones that are paying a little bit here? Or is that just not even possible? I don't know.
So this is where I will admit that I am still I think struggling with some understanding of I think the question was asked in the room is how ArrayRx is making money. And so this was I personally do not feel totally clear on that. I'm an optimist. And I do like to generally, believe that I want to live in a world where this is absolutely a pharmacy-friendly system. As someone, though, with the information that I have currently, I do not feel that I know one way or the other. I hope absolutely that it is. This is something that I want for us as a state. It's something I want for our patients. It's something I want for our profession. I think due to the complexity and perhaps the proprietary nature of their pricing, it's not information that I have currently to be able to say with a ton of confidence, yes.
Thank you.
I hope that there's maybe a path forward where maybe we can sort of get to that clarity. Forgive me, we don't have the information right now to be able to say that at this moment.
Thank you.
I think we're having a little confusion around the committee when we're talking about a fee.
Mm-hmm.
And because I think some of the things Lauren said might be differing a little bit from what we've come to understand in this proposal. And I think that there's a misunderstanding of what a fee is and what it's going for. And so maybe I might ask the treasurer's office if they'd like to come up and answer the question about when we're throwing around the word fee, what we're talking about. Okay. You on the spot, Peter.
Of course. I'll actually say it's my first time testifying for a legislative committee since I was 17.
Wow.
And it's fun to do it without having been thinking I was going to do it. But luckily I have Trevor here until 12:30 in the next 10 minutes to answer any questions if I get them wrong. As I understand it. Oh, yes, of course. Thank you. My name's Peter Trombley. I'm Director of Legislative Affairs at Treasurer Petrak's office. And as I understand it, when we're talking about an ArrayRx fee, this is something that's embedded in the price that consumers will see if they bring their ArrayRx card to their pharmacy or if they search through ArrayRx's online tools to find out what the price of their medication are going to be. So it's not an added fee on top of the discounted price. This fee is tracked separately, the revenue from each state by ArrayRx, by the staff at the Oregon Health Authority who manage this program. And then the ArrayRx Steering Committee agrees annually to a budget for the upcoming year of the program, subtracts the operational costs from that fee revenue, returns leftover fee revenue to the states, which I'm understood to be rather de minimis because this is a rather small fee. ArrayRx as a multi-state collaborative, of course, does not have a profit motive. We're operating at cost as lean as we can, so that we can keep this fee as low as possible. And it's my understanding, and Trevor can correct me if I'm wrong, that the more usership we see, the larger the negotiating power of this collaborative, the more we can try to bring that fee down over time.
So I just want to be clear. Somebody receives a price and they say to themselves, well, this is a whole lot less than I would have paid if I was going through my insurance. Embedded in that price that they're being given is a small nominal fee, which is passed on to Oregon Health, who administers this, and then passed through to the states based upon who used it. And it's de minimis. Thank you for using that word in here for the first time this year. I love that word. So, okay, and there is no, it's not like people go to the pharmacy with this discount and then they say, oh, you've got to pay a fee to use it.
That's true.
It's embedded in the price.
That is true.
Okay, so I'm understanding.
That is correct.
But does that mean the pharmacy, it comes out of the pharmacy?
Well,
Yes,
No.
Yes.
the
Yeah.
pharmacy pays it.
Yeah.
well, they,
Just to be clear, the consumer pays the fee. But
Pharmacy.
that revenue then, if a drug costs $8.50, the pharmacy is not keeping all that $8.50. A small portion of that is going to ArrayRx for the fee, but it's paid out of the consumer's profit, although it does, in that sense, that's a margin that's not being taken in by the pharmacy. Other cards, if I may, like GoodRx, as I understand it, charge an access fee to pharmacies to run the card transactions. ArrayRx does not.
If I may,
yes, please.
no. I'm sorry not to be like so blunt with it, but at the point of the transaction, so the pharmacy will run the claim and it'll say to me, hey, charge the patient, let's say nice even amount, $10. Charge the patient $10 on this medication that cost me $2. What the patient won't see is that they would also be telling me, okay, but also pay this PBM, let's say $1 to $2. So the patient will not see this and they will not interact with it in any way. But regardless of whatever discount card that is brought forward, and this is corroborated by my calls that I had made to pharmacies in states that do already use this, the pharmacy is paying these people. Like, that is how the money is being made. The pharmacy is paying. The patient pays the pharmacy, but then the pharmacy then pays for this.
It gets taken out of what the patient paid.
Mhm.
So, but the amount the patient is paying has the fee embedded into it. So if it didn't have a fee, it would have been a little bit less.
Or even to go so far as to say, if that fee wasn't in there in the first place, if pharmacies were just allowed to set, prices, which part of the issue is that pharmacies, given the lack of transparency with some pharmacies, that they just kind of set these arbitrarily very high prices. Maybe not arbitrarily. There is obviously a method to it, but it is still very, very high. That without that fee, the pharmacy could charge the same price and then not lose money to paying someone else to set whatever price they're saying to set. This is a thing that impacts independents more so than chain pharmacies, who the pharmacies at the time don't see these fees, and it's just their setup is just very different from the software standpoint. But the pharmacies pay to set these prices.
I was wondering if Trevor was still here. I know we only have him for a couple minutes, but Lori had a question.
So, is this process that ArrayRx has on the table any different than what's happening with other discount cards that are out there?
Not that I have seen, not that I have had told to me by other states who are currently using this.
Okay, there's a fee throughout each one.
Yes, the consistent thing that I have heard for the pharmacies that I have spoken to, and I have spoken to, I'd say I called about at least 10 in each state, was that there is a fee that is associated with it, an administrative fee to for these prices to be set, but the pharmacy is paying a certain dollar amount.
If I may.
Yes, please, Trevor, if you wanted to weigh in.
Chair, members of the committee, and thank you. I will say, fundamentally speaking, Dr. Quinn is correct. There is a administrative fee associated with discount card claims. There are other discount cards that charge access fees that the pharmacy pays that are not part of the transaction that we utilize. But I will just restate, I think your understanding, Chair, and some of the others around the table and what Peter articulated. The intention is that the fee is part of the total price that is advertised on the ArrayRx Tools site. And that fee is part of the payment made to the pharmacy. And yes, Dr. Quinn's correct, that part has to be paid to the PBM by the pharmacy. So the true net to the pharmacy is that total amount minus the admin charge. So it is, so if it's $10 claim and there's a $1.50, you're looking at $8.50 that the pharmacy retains. And so hopefully that answers and clarifies what was being shared.
I think so. Thank you.
Okay.
We really appreciate you being here. I think I'm going to thank
Can I just say one? I'm sorry.
one thing.
So I
I
just.
have my hand up too.
Okay, go ahead. You go, I won't go.
Oh, go ahead. You go.
Feel like I'm in a stop sign.
Okay.
Okay, somebody go.
I'm gonna go. I'm gonna go
Because
right
I'm
now.
gonna Shut us all down.
Yeah, go.
All right. First of all, that's not what we heard from the treasurer. At least I didn't hear that. I heard him say there were no fees. And I also heard him say that we've got to get in this thing quick because up to a certain point, you don't have to pay any fee. After that, you're gonna have to pay a fee. Am I right when I heard that?
I believe that what the treasurer may have been saying there is that there are no membership fees to sign up for the card. I think some of these other cards, you pay $25 at the time you sign up for the card. And there is no such fee with ArrayRx, though there is the embedded fee in the transaction. And if Trevor can correct me if I'm wrong, I believe that the collaborative is considering charging states a fee in the future to become members.
Yeah, but he wouldn't have to pay that.
Indeed, and I believe my understanding is that we would not have to pay that as a state.
In my comment, I just want to say to Lauren and Ryan, we in this committee are very understanding of the issues facing pharmacists with the way PBMs and others do pricing. So unfortunately, that's not what we're trying to fix here, but do know that we are understanding of that.
I was gonna mention.
I'm sorry.
In that, ultimately, this is a system that is not working for patients. And here we're trying to help patients. And we certainly understand the issues around pharmacies, which is a much larger issue. I'm gonna thank everybody for joining us. I really appreciate it. We can go off of live. And I will see everybody back here in 30 minutes. And
Thank you.
Lucky.
actually have
Sign, this is giving us the bill.